Live again, and we will give it another 5 minutes to let other people join in. I'm an engine guy. So goes in, goes out, 30 minutes later. Schedule maintenance. Job close. Not due till next week. Man, I've been trying some of this for a long time. Finally got it. We finally got it. Go up. Hey, where's Paige? Still on. Still on. Human being. I know you're being amazed by watching me on the screen, but yeah, that's how it's going to go until we get started. So enjoy. Feel free to judge and be nice about it. In 2 weeks. Carlos Solano, head of the Solano cartel, ships everything north via buses. Okay, so it's a plane. Yeah, 2 weeks. 2 weeks. Weekends on that bus. Jake's the guy who had the power control. Solano. We're about to see the drops, the guns, everything on that bus. But then fees on man and Google. Yeah, fast we can do this. Not you. What the hell is it? Crazy episode in 2 weeks on USA. Characters welcome.
I'm dark.
You need to get some light, honey.
Hold on. Let me fix it.
We're live, by the way, so people can hear you if they're
Oh,
watching already.
hey everybody.
I'll tell Anthony to edit this out of the recording.
Oh,
So I'll give my update. I'll tell you about everybody about Florida and Alabama, and then we'll have you talk about some of the fun stuff in Georgia, since that will be the case study, unless the Florida person joins us.
what fun stuff that's going on in Georgia, Matthew?
The problems you have in Georgia, and how we
Oh.
can think of some policy solutions to these problems. Specifically, Mr. Griffin, I'd like you to talk about this little plant called Grady. And I'm going to talk about some federal policy solutions that exist that might help somebody in these types of places and situations.
I'm sad to say, Grady's a good place.
For black gay men,
He has to get treated, yeah. That's, again, it's sad to say, but, you know. How do you know how many people are watching us?
you don't. That's the joy of the way Anthony has it set up. Because you can watch you and I on YouTube and not actually have to come into the policy hangout.
I don't like this. Mm-mm. Mm-mm. Maybe I should go grab some water or something. Oh, scary. So how would we take questions?
Via Twitter
Oh gosh.
and the chat function.
Oh God.
It's a multi-step process.
Jesus. I didn't sign up for all of this.
Yes, you did. It's called Welcome to Your Last Day.
Oh my God. Jesus.
I'm liking this color on you. It's very cute.
Thank you.
It's warm and sunshiny. Unlike your personality towards me lately.
Matthew, we're live. Don't do this.
I just wanted that on the record.
Don't do this. Scratch that. Let me open the tweet deck. What's the hashtag YBGLI?
Mm-hmm. Everything's hashtag YBGLI.
Hashtag it.
Unless we add a year to it. Then it's a summit hashtag. People, we will start as soon as Matthew finishes typing on Facebook to tell the children to join us.
You guys should be like retweeting that also.
Where? All right, gentlemen, welcome to June's Policy Hangout. We have a guest with us today to talk, as we talk about the southern states. We'll slowly start moving up, talking about individual states as promised and things that can be done from a policy standpoint based on what's happening in your state and what solutions we can come up with. Remember, you can tweet us at YBGLI. You can tweet me directly with questions at MTK Rose, ROSE. And you can just follow the discussion here. You can post in the YBGLI Facebook group. We are live and accessible. Feel free to ask us questions. But we will start with what's going on the federal level. Probably the biggest and most important thing that happened on the federal level relating to HIV actually doesn't say the words HIV in it. And that would be the President Obama signing an executive order to protect LGBT folks who work for the federal government. This means you cannot be fired from your job if you've got a good Fed job, or even if you have an okay Fed job. Now, job protections have been something that we have fought for ever and a day, and as many of you know, income and coin is key to keeping your butt socially mobile and keeping you out of vulnerability for HIV. That's not to say that it's the only thing that can keep you and that income alone will protect you, but it is a contributing factor. So having protections on the federal level, very, very important. Next, tomorrow, Friday, is National HIV Testing Day, which is the federal government's recognition that people should get an HIV test. I think that if folks have time, you should check out the statement released by the Counter Narrative Project that Charles Stevens does. Charles is a great young black man, well, not that young anymore, but still young in heart, down in Atlanta. It was a wonderful statement talking about the importance of testing, but what testing means. And I think one of the things that I took most out of there is he has a very important line about how testing makes us stronger, but it also makes us vulnerable because we are bearing our souls, our information, and our secrets and our truth to the medical system, which means it's important that the medical system be there to recognize the trust we have given it and acknowledge what care and faith we are putting in it. So tomorrow, National Testing Day. If you have not gotten a test in the last 6 months, this is a great time to go get yourself a test. It is insurance has to cover them as per the Affordable Care Act. so you can get yourself a free HIV test. Go get it done. It is an empowering moment for you who need them done. Be able to know your status so you can make decisions about your health. And, it's just cute sometimes to be able to, like, yeah, I know, and not have to worry, not have to stress, but just to be in the know and knowing for you because you want to know. And, be there, get a gaggle of girls and go get tested together. You don't have to tell each other all your statuses, but if you want to, that's an option. But just go and know. And even if it's outside of your normal testing window, you can always be supportive about tweeting about it, talking about it, telling folks to get tested. The last update, or the last two updates I'll give you, are actually around funding issues. The first is around a grant that HRSA, we all remember HRSA from the YBGLI Summit. If you don't, Google yourself some HRSA. It's a department in HHS that is responsible for healthcare centers, the Ryan White program, which is the payer of last resort for HIV/AIDS, people with HIV/AIDS and their health needs. It's a wonderful entity. It does a lot of the care and treatment stuff that happens around Ryan White and around HIV/AIDS. And also the ADAP money moves through HRSA. So HRSA had a big grant that went out, funding announcement that went out a few months ago, looking for someone to create a resource center for a collection of resources to support Black gay men. And we know that if you're going to support Black gay men around HIV, you have to talk about young Black gay men and HIV. So for the young Black gays, bisexuals, same gender loving, and men who have sex with men, there will be a entity who will be tasked with creating a resource bank. Now, we don't get to control who that grant goes to, but we can make sure that they prioritize our needs and that they are creating the types of information that we need. So keep an eye out for that. It should be announced before our next policy hangout. So the next one, I should have a name if you haven't already heard it, but be aware that announcement is coming, and it is vitally important because this is going to be a very key position. A lot of great organizations put in some amazing proposals, and we'll see what the government ends up coming out. The last thing that you should be aware of, and that should help inform your decisions from a policy perspective in the next month, is that the health department's funding FOAs are going out from CDC. So the Center for Disease Control puts out these giant block grants that fund your health department to do all kinds of disease prevention and treatment work. And these happen about every 5 years or so, and the next round is about to come out. And so all your health departments should be talking to your local community. So if you need to go kick in a door, or you need a phone number to know who to call, and just be angry and indignant, or kind at first, you can work yourself up to angry and indignant. Always leave yourself with room to go. But NASTAD has the list of every state HIV director, and those people would love to work with you on how to get money and programs to support Black gay men as they start figuring out their grants and how to apply for their grants. If you are worried and don't know how to go through that process and are intimidated about calling your person, call NASTAD, and you're going to look for Blake Rowley. That's right, Blake Rowley. Now, if you can't find Blake, he'll be able to give you the number of the new NASTAD fellow, who I don't think has been announced yet, but that person's job is to work on Black gay men and Black MSM portfolio. So they will be responsive to your needs because part of their job is to support you with the health departments. So just keep that in mind and be good about it. And that is all I have for federal updates. So we're actually gonna, so you don't have to keep listening to me talk. You can listen to Daniel. Daniel, if you can just tell us a little about what are some of the challenges that you see in Georgia. Daniel is not only the outgoing chair of YBGLI, but he has been one of the lead voices in Georgia for a long, long time, for as many years as I've known him, which we won't tell that amount of time because, we are on air and all.
Thank you, Matthew, for having me this evening. It's a pleasure to be here. I feel like I'm on the Huffington Post Live or something talking about things. But again, like Matthew was saying, I am here in Atlanta, Georgia, and specifically outside of YBGLI, I serve as a project manager of a, excuse me, of an MSM serial sorting project. Specifically, I would think one of the larger challenges I face every day is ensuring STI treatment is available for the guys that I see. So generally speaking, I see young black gay men and gay men of all other all of their races above the age of 18, and we test our participants at each of their interactions with us. And very often, our participants, especially our younger guys, will come in and they will be positive for chlamydia, gonorrhea, or trichomoniasis. Um, and once we test them positive, generally speaking, we would refer them to the health department. I would say more than half of the participants that will test positive for STI, once being referred to the health department, they're turned away. It doesn't make sense to me either. Um, so my biggest issue in any day, any week where I'm working is ensuring that young guys who I see, once they do test positive for an STI, they are treated quick, fast, in a hurry. Because we know if you have a sexually transmitted infection, it increases your chances of contracting HIV. So rather than, not seeking treatment ASAP and lingering or waiting it out, we, risk drives up for HIV infection, and we're really trying to turn that the other way around. So I would say that's the biggest thing I see every day of the week.
Okay. Thanks, Daniel, for telling us kind of what's happening in Georgia. Our dear friend Derek could not get on from Florida, but some of the things that he highlighted, as well as Christopher Bates, who is a wonderful long-term supporter of YBGLI, black gay man who's been doing this work forever. I won't say where he works because he might need me to protect his name in these delicate circumstances. But they had mentioned some of the things that they're seeing in Florida, and I think Florida is very interesting because it's some things we're seeing across the rest of the South. And they're seeing that there's a lack of knowledge about HIV, where to go, where to get options. There's a lack of testing services for just basic STIs and STDs and HIV. There's a lack of funding. There's a lack of critical thinking, and there's a lack of guidance. And these are, a lot of some of the issues that they're seeing coming up repeatedly.
I think the only surplus that the South has is a surplus of stigma from all levels. I think stigma is seen from the community. Stigma is seen from providers. And it just goes back and forth.
I think it's great that you mentioned that stigma, Daniel, as one of the discussions I had with some folks in Alabama is they said their biggest challenge is stigma, and not only stigma for just getting tested, but for even getting people who have the ability to do the work involved in the work, because they don't want to be that person in their community. They don't want to necessarily be associated with HIV in that way, whatever that way means. But I think that we should think about kind of what are the ways that policy can help address stigma. And I think that probably the first and foremost of those are, if you all remember last week when I had that nice fancy guide, it's posted on our website, about what you can do with the Affordable Care Act and what the Affordable Care Act brings. And probably the most important piece in there in terms of stigma is stuff around non-discrimination. So the Affordable Care Act has all kinds of provisions and reporting mechanisms for you to say what the hell happened to you, what went wrong, and let someone else figure out how to make it better. But all this is predicated on people being able to report. So you have to know where to report. They do make forms at HHS, so if you go to the HHS website or go to AIDS.gov and from there link to HHS's website on saying, you faced discrimination or you felt like you faced discrimination, that's one place. NASDAD, who we mentioned earlier, is doing a giant stigma project with the health departments. So they're collecting data on stigma and figuring out how do we change stigma. That's a place to go. If you want to be cheeky in your own health setting, all the hospitals in this country are kind of looked at by this commission called the Joint Commission, or the JCO standards. And JCO has specific provisions around non-discrimination based on sexual orientation, gender identity, and gender expression, which of course you could stretch to cover yourself for HIV. But there's also a lot of disability law that protects HIV status. However, most of this is all only relevant and useful if folks use it. So you have to feel comfortable, and even if you don't feel comfortable, sometimes it's okay to be a little uncomfortable, but going forward and filling out complaints. And if you have issues, by golly, email someone. There are people who will walk you through or refer you to someone who can help you, but don't let your bad experience be this bad experience that turns you off to the program, because I bet there are hundreds of other people who had a similar experience, and because no one said something, these bad things continue.
Yeah.
Daniel, ideas for stigma for you? What have you done in your kind of area that you felt has helped alleviate stigma? What do you do in your clinic to make people feel welcome and accepted for who they are?
I think the simplest things the simplest things are things we take for granted every day. So I think the first thing is, greeting people. Hi, how are you doing? Letting all of our participants know that they are a person, They're not just a research subject or a participant identification code, but, you're Bam Bam, or you're Rocky, or you're Jasmine. I think that goes a long way. I think the second thing we do, if you have an issue or if you have a concern around, I was mistreated, or this could be an issue, we talk about it. You can pull any one of our project managers to the side. It's two of us here in the city of Atlanta, and then we have one outside of Atlanta. But even not our project managers, you could pull any of our research assistants. So I think, knowing that we have an open door policy, that's a big thing. And I would say the third thing is frequent trainings. So specifically on my staff and anybody who works under our project, we have yearly reviews of cultural competency, cultural sensitivity. We document when we have adverse events. It's a little bit easier since we are in research. And each year, prior to renewing or going forward with our next year of the research project, we have to take a look at our adverse events, see what happened, really examine what happened, why did it happen, and how will we make sure it won't happen again. So I think if agencies and other organizations actually begin with those 1, 2, 3 steps, that could be the beginning of alleviating some stigma.
And from a policies perspective, things that Daniel is saying that come to mind are, he's talking about training. So you can talk about ways of writing cultural competency requirements and specific training requirements as part of personnel policy. You can talk about how you create a workplace environment policy or staff greeting policy. So it's explicitly read out for all new hires that when someone comes in the door, that they are greeted with a, "Hi, how are you? I'll be with you in whatever amount of time," just so that that person's acknowledged as a person. And these are things that people don't traditionally think of as policies, but these are routines and practices you can put in place that definitely are policies of sorts and are policy outcomes that you can look up at an organization, see if they exist, and then test them to see if they're actually adhering to them.
Yeah, Yeah, I definitely think, it's a firm believer of, I'm a firm believer, if it's not in black and white, it won't happen. So I definitely think those are policy recommendations, and I think those forms of recommendations should be in any FOA announcement that is to come from any level of the federal government or even private foundations.
Definitely. And I think that those are things that we try to track and pay attention to, but a lot of that is predicated on being able to know what's happening on the ground, which is why it's so important that people tell folks what happens. One of the greatest things that I love about our summit is that it gives me the opportunity to meet people who I haven't ever gotten a chance to speak to before, and just have them tell me what's going on the ground. And if the policies that we're pursuing for them in Washington and around the country and the world in some instances are meeting their needs. Because at the end of the day, it's about what's going to be useful to you, what's useful for your community, and how we can help you. Now, if you're trying to think about how to write some of these things, there's no reason for you to start from scratch. There are a zillion great standards on how to do good cultural competency policy and write that in requirements. Some of it's already written. You just have to get enforcement and implementation down. So it's really just about figuring out what's happening in your area and who are creating the roadblocks. So if there is a policy in place that's not being followed, who's responsible for enforcing that policy and why aren't they? And who can you pressure to help make them change that? And in some cases, it's a hospital administrator that's high up and sympathetic. Sometimes it's a donor who wants to, change a particular cause and can give you influence over a certain area. Sometimes it's a politician who's running again for office. I'm looking at all of you people in the South on this one because voting, very important in HIV prevention, because you need to vote in people who are going to care about your issues and at least try to pass funding policy and larger scale policy and reform that will benefit you. So let me look over to Alabama again. One of the things I got at Alabama was we're trying to figure out how do we get people educated and motivated, and what are policies that might help do that. And I think that what jumps to my mind are after-school programs on education, especially health education. Mentoring programs are super important and key, and finding ways to get those funded is really difficult, but there are options. The Department of Ed does release some special projects funding every now and then. There's stuff that there's health educator funding that can be found, especially in the state health department's money. Daniel, anything come to your mind?
No, not right now.
Okay.
This is hard to do live on the spot.
I know, that's the best part about it, girl. We're live and ready for the people.
Jesus.
I'm just checking Twitter to see if we have any additional questions.
Someone said there's a question on the board, but I don't know what board they're talking about.
Oh, let me check the YBGLI board. It might be there.
Send me the link for the YBGLI board. I don't use these contraptions. I just like to talk to people.
Don't let Daniel fool you, people. He is all about the questions, and he's all about the technology.
I don't see the board. Where's the nice webinar lady that is speaking your ear?
Right. See, people, when you get real fancy with these webinar things, you can have someone ask you these things, ask questions for you live.
Even if we had a secretary to do it, that would be good.
Mm-hmm. But we're real basic. We have computers. We making it work.
So someone asks, what stigma exists around PrEP? So why don't you tackle it first?
Sure. I think some of the stigma that exists around PrEP is there's a lot of shame about our sex, about the sex we have, about the sex we enjoy, about the sex we want to have, about the sex we fantasize about, and what decisions that people make to have the kind of sex they enjoy but for some reason people think that it's wrong or icky or something else, other reason. And what we're seeing a lot of is that what's traditionally we're hearing is that people get called cum whores or chuvada whores, or that, oh my God, people want a bareback. And I always like to bring it back to one of my favorite HIV writers said, your mother liked it bareback. And I think that the expression there is that a lot of the world has bareback sex. A lot of people have sex without a condom. Sex without a condom happens. Does it need to happen all the time? Depends on the person. But PrEP, people think that, well, you're just trying to have sex without a condom because you want to be irresponsible and you want to be a cum whore and you want to bareback. And for some reason, we have this stigmatization around it for thinking that this is bad. I tell you that people's sexual desires, as long as they are healthy and consensual, are all good. But they need to be informed, and you need to think about what risks you may or may not be at, and how do you manage those risks. And PrEP is one strategy for doing those. Because to be honest, you can still get chlamydia, gonorrhea, and syphilis when you use a condom. True talk. You're more likely to get them if you're not using a condom, but there's risk in everything you do. Sex is risky. But that doesn't mean that we need to make someone feel bad about the type of sex they choose to enjoy. We should allow people to make decisions that will give them the best protective option for themselves and let them make informed decisions. We give you the information, we tell you what's going on, and then we tell you, you have to make a choice. And we hope you that as an individual, you will make a healthy choice for you.
So I think some of the other stigmas that exist around PrEP is, thinking about the use of it. So will I have to swallow this pill forever, Or can I just swallow this pill when I'm at risk or partaking in a risky environment? I think other stigma exists around the mistrust when it comes to the medical model and our interaction. Specifically thinking about past horror stories and past horror projects that just went wrong. And I think the first thing that always comes to our mind is the syphilis project down in Tuskegee that went on for 40 years. I think stigma exists around specifically race in the medical model. So whether or not as a black person or whether or not as a black gay man, will my health outcomes be better or will it be worse in comparison to a white heterosexual, white gay man, or even other females? So I think those are some of the top things that come to mind when you think about stigma and the use of PrEP.
And I think, again, it gets back to finding ways of normalizing the discussion. And I sometimes hate that word because what is normal? But we'll say for now, normalizing means making it so more generic, more commonplace of the discussion. And if you find policies that support these things, like the ability to talk about PrEP, it was a big deal when the CDC released their guidance because a lot of people started talking about PrEP and talking about kind of ARVs, antiretroviral-based prevention options. And I think that lost in that discussion, and I think this is why PrEP kind of gets stigmatized too, is that we don't talk about all the ways we use antiretrovirals to protect us from HIV. So talking about treatment as prevention as a public health strategy, if we can kind of close the gap and get everyone who wants to be at virally suppressed, so they can have the same health outcomes as a person who's HIV negative. If we can get, if someone has an exposure and wants to be on PEP and wants to take a 28-day course of antiretrovirals to reduce their chance of infection by 72%, knowing about that option. But I think that we become so hyper-focused on PrEP that it becomes this lightning rod of like, oh my goodness. I think PrEP is an acknowledgement of shit happens. PEP is an acknowledgement of PrEP is acknowledgement of shit happens, or you might like it that shit happens, or I just need to do me, and me is a little different than you right now. But PEP is an option of that shit happens. And so you want to be able to have that. Treatment as prevention is an option of let's help someone who's already healthy, and here's a cool extra benefit that happens on top of making them healthy. So I think it's when we broaden the discussion to make it not so focused on things like, oh, you just want to have bareback sex all the time. We make it better and nicer and start kind of tackling this stigma problem. And, you know, as I tell people, stigma kills. I mean, the reason that people are afraid to go into getting prevention options, the reason that people are late to diagnosis, and stigma kills us black people more because, let's be real here, I mean, we're always at the bottom of most health outcomes. And when we are afraid of our HIV statuses, we are afraid of HIV, we are afraid to go get that test, we are afraid to be on treatment, we are afraid to figure out what our prevention options are and how to use them, or to be able to talk about the sex we're having, it exacerbates these problems and it damn will kill us.
Cool. So I have another question. How are we going to make PrEP real for Black MSMs?
Oh, well, there's a couple options. Do you want to take this on first?
This is your show.
Oh, okay. I think the first way is we need to know how Black MSM actually feel about PrEP. We know how the white girls feel, for lack of better words on this. I mean, we see the discussion in the paper, but if you'll notice, there's never really a lot of discussion about Black gay men on PrEP and Black MSM on PrEP, and we need to own our part of that narrative in that conversation. Even if we aren't using it ourselves, we need to own what it means for it to be an option for us. Because when we don't do these things, other people make these decisions for us, and then we end up in this, well, shit, we just got screwed. So one of the great ways that we have is that HBTN, that's the HIV Prevention Trials Network, has a trial 073, which is a trial for Black gay men created for Black gay men, which I always thought was a funny thing to say. But they are doing a trial to look at are Black gay men interested in taking PrEP? If they are, what are the circumstances and support mechanisms that need to be in place to make them successful on it? And I should say it's not just for Black gay men, it's for Black gay men, bisexual men, same gender loving men, men who have sex with men, straight men who have same gender expressions and behaviors and experiences.
They're important.
So it is an opportunity that will give us some data. It has a very robust set of questions. They're doing some rigorous testing, and it will give us a peek at kind of what the population needs. But I think what's more important is that you have these discussions with your friends, talk to people about what they think, what they feel, would they be interested in taking a pill every day? We know that insurance has not been an issue for it. So it's really about figuring out, do we want to take a pill every day? And when they say you need to take it every day, they really do mean you need to take it every day. Because the only data we have that tells you that it's very effective is when you take it, when you have high adherence use, so almost daily usage. So it's a discussion of, if you're already taking, 4 or 5 vitamins a day and you're used to a pill-taking culture and you're already popping those, throwing back those pills anyway, what's another pill? So it's really thinking
more than that.
Yes, it is definitely more than it's just another pill. Don't get me wrong here. It is a very serious and important and critical discussion that you need to have with you and your doctor. If your doctor does not want you to take it and you are still interested, you can talk to. There are groups that can help you find some folks to talk to who can prescribe it. You do need to see a doctor to take it, and you need to see that doctor at least 4 times a year. So you're really committing to a decision about yourself, about your life, about where you think your risks are, where you think you want to be, and how willing you are to engage into an intervention that is going to require some changes in your life, because you're going to need to see your doctor at least 4 times a year. You're going to need to take a pill every day, and you're still going to need to be aware of other things and other STIs and STDs that are out there that aren't protected from the environment, from the pill. So it's definitely not a miracle drug. I think that, that there's a niche of our population, just like there's a niche of every population that will be interested and want to take it. But I think that in a conversation that you have to start internally with yourself about what you really feel about your sex life and the kind of sex that you enjoy having, and what you're doing. I tell people, if a condom works for you, you don't need to throw out the baby with the bathwater. The condom's fine. I mean, it does its thing. But if you want a different option, or if you want an additional option, this might be something to explore.
Right, definitely. And I think PrEP can look anyway for Black MSM. Whether or not we choose to access it at, your CVS Minute Clinic or your Walgreens Wellness Center. I don't think it necessarily has to be accessed at your primary care physician or even the health department. But I think we have to start having the conversations on, where do we access healthcare from?
Yeah.
And
a shout out to, I would be remiss if I didn't say this, a shout out to the nurses and nurse practitioners who have been playing a pivotal role in prescribing PrEP and supporting people going through who are on PrEP. So there are a lot of
practitioners, social workers also.
And social workers too. That healthcare system is large and robust, and you will get your help. You just need to figure out who is there for you, who do you feel comfortable with,
right,
and who do you want to have these conversations with.
Right.
But I think that to get back to the kind of the root of the question, it's up to us right now to decide what PrEP looks like for Black gay men, and if we want it. We have that choice, and it is an option that exists. It's out there. It's proven effective. There are people figuring out how to best support us if we choose to take it, but it's up to us to decide if it's the intervention we want, and if it's not, what other interventions do we want? And I like to remind people that we want to make a smorgasbord. I want you to have a buffet. I want you to open up that handbag and say, look at all the prevention tools I can choose from. Let me grab this one and this one, or maybe this one. And by me grab, I mean I'm probably going to hand them out to people because I'll know which one I want for myself. But let me give you some options, and you figure out what works best for you. And this just is the latest. So with PrEP, now we have PrEP, we have condoms, we have the female condom, which has now apparently been better improved, so it's less noisy. We have treatment as prevention, and we have PEP. And so we're at 5 options. And when we started this epidemic, we had 1. So
more than 5 options.
We have more than 5.
Behavioral intervention.
Some behavioral interventions. Hold on, let me say we have 5 biomedical-ish options. And I will say, Daniel, I personally believe that everything is a behavioral intervention.
Everything is a behavioral intervention, yes.
Because if you're going to taking a pill a day is a behavior, y'all.
Yes, it is. Yes, it is.
Going to see your doctor, a behavior. Opening up to your doctor, a behavior.
I'm right there. I'm right there with you. We will have microbicides soon. We will have
you have a gel in your booty. You could have a shot in your arm. The pipeline is rich and expressive. You just got to figure out what you want.
I think there's something for everyone, and I think we really have to have the conversations around what best will be for you.
And you be vocal and active in those conversations, because that's going to be key. I mean, it's the same way for policy. Like, we only know the policies we write that work for you when you tell us what you need, and then after we write them and get them for you, you tell us if they're working. If they're not working, right, we need to fix it and find something new.
Right.
Do we have any more questions? You see anything else? I'm scanning the Twitter.
See. Shout out to Junior's Realm for following us tonight. He's posting pictures about the summit. Let's see who he is. Do you have any questions, Junior? I mean, tweet us. Come on. I think some other ghosts are out there. I think Blake is out there in La La Land. Blake will be our incoming chair for the Young Black Gamers Leadership Initiative. So definitely be on the lookout for all the amazing things that he will be doing this upcoming year.
What we're saying is, don't look for Daniel and I. Go to Blake first.
We'll definitely be here. I don't see any other questions.
Okay, well, thanks everyone for joining. Those who couldn't join, there will be a recording that will be up on our site in the next couple days, and we look forward to telling y'all more in July. I'll probably have a couple more guests in July. We'll do some more states. My last parting wisdom is that, and I'm going to say this for every webinar, every one of these between now and November, vote. Voting is so important. If you are not registered to vote, slap yourself in the face, wake yourself up, and go get registered to vote. Our community must show up out in numbers. All right. Thanks, people. Thank you, Daniel Driffin, for joining us.
Thank you. This is great. I'll be back.
All right. Bye, y'all.
Bye-bye.